Thank you. So I thought I would take a little bit of a different approach today. I wanted to help with some diabetes self-management tips for patients. And I also wanted to go over some frequently asked questions that I get often in my clinics from patients and other providers. So I pulled a lot of this information from the American Diabetes Association and some different journal articles. And if you're interested in those, I'm happy to pass those along after our talk today. So just please reach out and let me know. Next slide, please. COVID-19 has emerged as a global pandemic affecting more than 200 countries and claiming thousands of lives. Diabetes has emerged as a distinctive comorbidity that is associated with severe disease, acute respiratory distress syndrome, and increased mortality in COVID patients with diabetes. Next slide, please. It's an independent predictor of admission to intensive care units or needing invasive ventilation or death in patients with COVID, even after adjustments for age. Maintaining good glycemic control would boost the innate immune system and help prevent the grave consequences. However, as a result of nationwide lockdowns imposed to curb the spread of the pandemic, comprehensive diabetes care and glycemic control has had some changes. Next slide, please. Some challenges to diabetes self-care amid the COVID-19 pandemic. So lockdown and social distancing has limited physical activity. There's restrictions in food supplies during lockdown, and this has compelled people to change or alter their diets, sometimes leaning more on high carb diets. Obtaining anti-diabetic medicines has often been more challenging due to fluctuating pharmacy hours, closures, shortages in medications. Physicians' visits have also changed and routine follow-ups may be more difficult. Next slide, please. And to touch on the psychosocial health of people with diabetes amid the pandemic. So this has definitely adversely affect the psychological well-being of people all over the globe. The constant anxiety of unknowingly contracting the virus, the stress of being in lockdown within their house without being able to interact with family, coworkers, friends as much or not at all, markedly affects the psychosocial health of the masses. And the sudden and near constant stream of news reports and outbreaks can also contribute to underlying stressors. I actually was in touch with a psychologist this morning, and he had told me that there is a 500% increase in both drug and alcohol sales, and in addition, firearm sales since the pandemic, which is startling and shocking. I did not know that as a statistic, but in addition, he had mentioned there's an increase in a 25% divorce rate. So I think being mindful that, our patients are really struggling throughout the pandemic, not just with, chronic diseases, but a lot of other psychosocial issues is really important because, if we're not addressing the psychosocial well-being of our patients, it's going to be really hard for them to address diabetes if the other things in their lives really aren't being addressed as well. Next slide, please. Patients should feel free to discuss their psychosocial issues with, routine physicians, primary care doctors, with us through telemedicine or telecommunication, as well as, in-person visits. Physicians should also inquire about, the state of mental health in our patients, and then they can coordinate telehealth visits with their providers if it's difficult to do face-to-face visits. I had talked with a psychiatrist earlier, and he had said they're still doing quite a bit of telemedicine. It's still covered, so those are options for our patients as well. Next slide, please. So in the wake of the ongoing pandemic, optimum diabetes care can be achieved by, only adopting a collaborative approach to self-management practices that involves a multidisciplinary team comprising general physicians, endocrinologists, educators, nutritionists, ophthalmologists, podiatrists, and psychiatrists. And diabetes self-management education refers to the ongoing process of facilitating knowledge, skill, and ability necessarily to successfully manage the disease on their own. Next slide, please. So the mode of communication between healthcare providers and people with diabetes amid the COVID pandemic. So just be aware that they may not be able to visit their treating physician in person or as often. And teleconsultation, again, is an important role that's being played during the pandemic. Most people have smartphones, so they can do this out of their household, but they should be made aware that there are phone, video visits, and face-to-face visits for whatever needs they may have. I have a lot of patients in West Virginia that don't have cell service where they're at or internet, and they sometimes go to hotspots or friends' houses to do their visits as well if they can't travel maybe 2 to 3 hours to Morgantown. So that's an option as well. And then I just wanted to let you all know too that diabetes, there are group visits through WVU that are still being offered, and those are kind of group visits with roundtable discussions if patients do want to come into the office. Next slide, please. So dietary changes to be made aware of, just encouraging healthy diet. So low carb, more fresh fruits and vegetables, avoiding sugar sweetened beverages at home. As far as groceries go, making your patient aware that they can be picked up or delivered to their door if they wish. There's a lot more options now for groceries during the pandemic. And then I always encourage patients to keep track of their calories and intake with MyFitnessPal. There's a lot of apps that help do that. It's much easier to snack when you're working at home or when you're quarantined. So keeping track of your calories really can help. There are resources at the American Diabetes Association that give patients kind of like the plate method for higher protein, higher fiber, and the amounts of protein, fiber, and carbohydrates that should be on the plate. So I encourage you to look at those. They also have recipes on there that have lower carbohydrate and follow typically the Mediterranean diet. And then referring patients to diabetes education. This can be done via telemedicine as well. There's also free courses in basements of churches or through local hospitals if your patient needs to find diabetic education. And then I think a newer thing during the pandemic has been just virtual everything. So cooking classes for patients with diabetes are offered, and there are some free classes, and I'll give you just some examples of that on the next few slides. So let's go to the next slide. So this was from the Food Network. This gentleman has diabetes and does free cooking and diabetic, demos on YouTube that they can pull up if they have the internet. Next slide. This is from Hoag in California. They have, if you look at the bottom right, they have free diabetes cooking videos and demos. And I think that's also great, for patients who are quarantined, stuck at home and want to change it up or learn how to incorporate healthier foods. Next slide, please. More free diabetic cooking classes, just more examples of resources and ways that they can get involved in virtual cooking classes at home. Next slide, please. It's important to help our patients stay connected to the world. During the pandemic, I think a lot of patients feel really disconnected. So I typically in my own clinic recommend joining support groups. The American Diabetes Association has that, and I'll give you an example on the next slide. There are newsletters to join, social networking opportunities. So for instance, WVU has a type 1 diabetes mountaineer group on Facebook to join so that they have kind of a support network and they don't feel so disconnected. Next slide, please. This is one of the newsletters, and this is from the American Diabetes Association. The patient can join through the links online. Next slide, please. Physical activity should always be encouraged, especially during lockdown quarantines. It may be harder to get physical activity. So some of the things that I typically recommend are exercising outside if there's a safe area around the home, Again, there's free YouTube exercises and videos online for everyone, and even patients that do have diabetes. So I encourage patients to look into that. There are some more costly issues. So home equipment can be purchased, and again, they're costly, like Nordic Track and Peloton, that have comprehensive workout programs in your house. And then, brisk walking. There's local mall opportunities. Are in Morgantown. There's the Greenbag Mall, and I encourage patients to go there. It's open in the mornings where less people are physically in the mall. So walking laps in the mall is a helpful thing a lot of my patients do, or swimming if possible. And then I always just exercise, caution patients that haven't exercised and are beginning for the first time, if they have neuropathy or coronary artery disease or a stroke, and making sure that they talk to their cardiologist and their primary care doctor before intense physical activity at home. Next slide, please. This is through the American Diabetes Association, and this is resources for patients on how to do exercise at home to get back in shape, and they have great links and suggestions online. Next slide, please. Exercise tips from the ADA are at least 150 minutes weekly, breaking up sedentary time. I know before we've talked about the ADA has a recommendation that we shouldn't be sitting for more than an hour at a time. So getting up and walking throughout the day, and then balance the training that we do. So incorporating some kind of weightlifting into the program. As we age, we do lose muscle, unfortunately, and then making it fun. So there are even video games that are designed for all age groups to get a fun workout at home in. And then if they are working out, I just have a tendency to tell them to avoid, high sugar drinks, Gatorade, those sorts of things that have a lot of carbohydrate in them. Next slide, please. So at home, I get a lot of questions about self-monitoring of blood glucose. I encourage them to check their sugars 4 times a day, if on insulin 4 times a day. Typically, insurance companies will only pay for 1 strip a day if the patient is only on 1 shot of insulin a day or basal insulin. And if they're only on orals, blood glucose strips typically are not covered as well. Strips are costly, and the supply at local pharmacies may dwindle from time to time. So I tell patients getting enough supplies in advance. With the pandemic, I've definitely heard of issues, strips being difficult to find at their own local pharmacy. So looking at other pharmacies and making sure that they have enough supply in advance is important. Considering continuous glucose monitoring is always something I try to get in every patient with type 1 or type 2 diabetes. It's definitely more costly, but that's another way to self-monitor at home. And then encouraging patients to stay on healthy sleep-wake cycles and eating routines. During the pandemic, I think that patients who may have different job changes or be quarantining, the sleep-wake cycle can get really reversed. And I find a lot of patients sometimes are staying up throughout the night and waking up during the middle of the day and eating really erratically. So I try to tell them to get on a healthy sleep-wake cycle and a habitual eating routine and a habitual self-monitoring blood glucose routine too. That all helps them to care for themselves in the setting of diabetes. Next slide, please. Medication issues. So just be aware there are financial limitations that can require changes in their regimen. And this is at all times, whether we're in a pandemic or even pre and post pandemic, medications are expensive, and being mindful that even more issues can occur during a pandemic with job and insurance changes. Drugs can be difficult to obtain too. So, for instance, the new Wegovy med that I get asked about from patients often, there were some supply issues with that. And I don't know from day to day how those supply issues are improving, but I know that in writing it, it was difficult to obtain. Patients, we mentioned, may have lost their jobs or changed insurances. And so maybe cheaper options or medications may need to be substituted. And then just be aware of utilizing drug programs. So there's coupons online to help cut costs, such as, If I'm writing Trulicity, I'll refer patients to the Trulicity website, and there's typically like a savings card online that will walk the patient through getting, I think the Trulicity one was like $25 for 12 pens, and they just need to enter their insurance information, their pharmacy information, and that sort of thing to be able to get help with drug coverage. And then I often refer patients to social work and case management. Unfortunately, I had a patient in clinic this morning who was homeless. And so this patient was on Trulicity and couldn't afford a home, let alone affording Trulicity. So understanding their social circumstances and helping reach out to social work and case management, I think is really important more than ever for patients as well. Next slide, please. This is directly from the American Diabetes Association, and I put the website down there. It's insulinhelp.org for patients who need help obtaining or paying for their insulin, and this is for you and patients. Next slide, please. Things that we should be mindful of in teaching and reminding our patients, especially if they're not seeing their providers as much, are review the warning signs of diabetic ketoacidosis, having all meds, ketone strips, extra insulin and supply at home. Again, this morning, I've had a lot of cases this morning that I can share with you. Another patient I had this morning was traveled to see their family and was stuck in another country because of quarantining, and was in that country for 8 months and had to substitute a medication, and the medication formulary and the pill was different in that patient's country, and they couldn't obtain the medication that they were typically obtaining here from their pharmacy. And so you can imagine that those things are also really difficult to deal with. So trying to get patients to get enough stock of their medications before they travel out of country, or even, domestic in country flights, making sure they have enough medication in case there's pharmacy issues with where they're going, I think is more important than ever. And then I also review red flags of retinopathy with patients. I've had a lot of patients say they haven't been able to see their eye doctor or have their eye visits canceled or pushed back because maybe they don't want to risk it going out. So just the red flags, double vision, blurry vision, those types of things, and seeing their eye doctor immediately if they occur. And then reviewing foot care practices. So checking their feet daily, using a mirror if they can't look, down at their own feet. Importance of vaccines and where to get them. I have a few slides that help with that. Importance of proper mask wearing and hand hygiene. So anytime they're going out, very important to be protecting themselves. If traveling, we kind of mentioned extra supplies, medications, flight delays to be aware of. I have a letter that I give my patients who are traveling to make it easier for them on flights that state, the patient is carrying insulin. They need to have on their person insulin at all times with a blood glucometer or continuous glucose monitor if they're taking flights, which can be helpful. Next slide, please. So this is from Health and Human Services in West Virginia. And if you're logging in from other states, I'm sure your state has a similar site. But this is a vaccine website of where they can get their flu vaccine if you log in, and it's all throughout West Virginia. The next slide, please. This is also from Health and Human Services of West Virginia. If your patient has questions on where they can get their COVID vaccine throughout the whole state, this is the information line for that. And most states have this. If you're, again, logging in from another state, you can find this through your own Health and Human Services website for your own state. Next slide, please. I wanted to kind of switch gears and go through some just day-to-day kind of knowledge that I things that I get asked from my patients and things I try to share with them. A lot of these things I've gotten from the American Diabetes Association website or the CDC, but these are frequently asked questions that I just wanted to review with you, and I hope this can help you in your clinics too. So I often get asked, are people with diabetes more likely to get COVID? At this point, it's unknown whether they're more likely to get COVID, but if patients with diabetes do get COVID, they're more likely to have worse complications and more severe symptoms. And this goes with, when you're getting infected with any virus and you have underlying diabetes. And then there's risk of getting the risk of getting very sick is likely to be lower if diabetes is well managed. Next slide, please. Another question is, are the risks different for people with type 1 or type 2 diabetes? So the CDC continues to update their website as new information pours in and clinical trials become available on this. But currently what the CDC reports is people with type 1, type 2, and gestational can be at an increased risk of severe illness from COVID. And because COVID's a new disease, we don't know as much as we'd like to about the underlying medical conditions that increase the risk for severe illness. But it is thought that diabetes generally does have an increased risks. Important to note that people with either type of diabetes can vary in age, complications, and how well the disease is managed. And this has a really big impact on how patients with diabetes, their course of COVID and how they deal with COVID is seen is really how well their disease is controlled, their age, many different factors. Next slide, please. I often get asked if patients need to worry about diabetic ketoacidosis. So when patients are sick with a viral infection, there is an increased risk of DK or diabetic ketoacidosis that's commonly experienced, more so in patients that do have type 1. And we want to educate the patient on sick day rules for diabetes. And I have a slide coming up on the sick day rules that I share with my patients. And then I also encourage patients to wear a medic alert bracelet to alert EMS providers if the patient does have diabetes. Next slide, please. So some of the sick day rules for patients with diabetes, I get this straight from the American Diabetes Association website and share this routinely. So drinking lots of fluid if the patient's having trouble keeping water down, having small sips if they can't really get a lot in and if it's making them nauseated. And this is to avoid dehydration. If they're experiencing low sugars, less than 70, reminder on how to treat hypoglycemia. So eating 15 grams of simple carbs, easy to digest, like honey, jam, jello, hard candy, popsicles, juice or regular soda. And I typically try to caution them on juice or regular soda because I think often, the recommendation is about 4 ounces, but I think that people often take a little bit more than the 4 ounces. So, half of a cup or 4 ounces of juice is really all that's needed to treat a low. And then checking their blood sugar extra throughout the day and night if they're ill, generally 2 to 3 hours. A CGM is great for this. If the blood sugar is running high, typically greater than 240, more than 2 times in a row, to make sure that they're checking for ketones to avoid acidosis or DKA, and then letting their doctor's office know. If they have medium or large ketones in their urine, then I typically refer them to their local emergency room. If they have small amounts of ketones, I tell them to just make sure they're staying really well hydrated and avoiding those sugar sweet beverages that we talked about avoiding. And then being aware that some CGM sensors are impacted by Tylenol is important. And then checking finger sticks to ensure accuracy if their continuous glucose monitor is reading too high or too low, which would be less than 70 or persistently greater than 180. Now, washing their hands and cleaning their injection or infusion sites and finger stick sites with soap and water, rubbing alcohol is really important. Next slide, please. I often get asked if COVID does cause diabetes, and there's not enough data to support that claim. There have been articles and case studies written. This was from the New England Journal of Medicine. It was a correspondence on new onset of diabetes and COVID, and there are ongoing registries. So patients that have newly developed diabetes after COVID infection, you can see there's a COVID diabetes registry nationwide that's really looking into this right now. But yes, there have been, case reports and studies that have been reported on that. Next slide, please. And I will like to mention to you as well that we know a lot of viruses. It's been shown previously that viruses can precipitate, diabetes. So that also is something that we should all be aware of, that any virus can really prompt, new onset diabetes. Next slide, please. Another question, if I live with diabetes, is it safe for me to work during the pandemic? So this is also a really complicated question that I get often, and I've looked in my own personal clinic for resources to help me in answering this. I definitely ask the patient to look to their primary care doctor and the CDC. I tell them it depends on many factors, including their own health and their particular job, the type of work that they do, and whether they're able to reduce their risk by things such as wearing, personal protective equipment, working behind plexiglass shields, working outside, or staying away from others will all factor into their risk of exposure. And then for more information on the risk and options, the ADA has a frequently asked questions site for workers, and I'll show you that website in a minute. The ADA also has resources for physicians as well, and this includes a sample physician letter that requests reasonable accommodations and a letter to the patient's employers, which is really nice because you can use that as a template or a smart phase in your clinic if you need to help your patient in writing to their employer for special accommodations. So next slide, and I'll show you a little bit of that. So this is from the American Diabetes Association. I refer patients to this. This is rights for workers with diabetes during the COVID pandemic. Next slide, please. And this is an example of a physician to employer letter. And I put the website on there for you. I think it's really helpful if you're trying to help your patient get any kind of special accommodation. Next slide, please. Businesses have begun to reopen in my community. Does that mean it's safe to go out? So there's no way to completely eliminate the risk of infection. So understanding the risks and prevention measures available help the patient to protect themselves and reduce the spread. And the risk of an activity depends on multiple factors, especially for those with increased risk of severe illness. Next slide, please. So these include, is COVID-19 spreading rapidly in your community? We have the potential to have close contact with someone who's sick or anyone who is not wearing a mask and may be asymptomatic. Do you take everyday actions to protect yourself from COVID? Risk levels may vary dramatically depending on the specific activity in the community. That's why it's important for the patient to consider their own personal situation and the risks to themselves, their family, and their community before venturing out. The CDC has a lot more guidance there as well. Next slide, please. Are there ways to reduce the risk of COVID when going out? So in general, the more closely a patient interacts with others and the longer that interaction, the higher the risk of spread. Activities are safer if they maintain at least 6 feet of space between you and others. They're held outdoors, or activities indoors with less ventilation are more risky and often make it harder to stay apart from other people. And then people are wearing masks, or interactions where one or more people aren't wearing masks create an increased risk. Next slide, please. So those are some of the frequently asked questions I get, and kind of how I kind of handle them. I think that I rely a good bit on the American Diabetes Association, the CDC. I also try to keep in close contact with the patient's PCP as well, and I send my notes and messages as much as I can. And that's kind of been my experience over the 2 years of the pandemic. I hope it was helpful. And if you guys have any questions, I'd love to answer anything that may come up.
Sorry about that. I think the Hollywood squares kind of shifted on my end, so I lost myself to unmute. But thank you so much, Dr. G. Always a wonderful job and such great information. Dr. Rexrod, I noticed you raised your hand, so I'll turn things to you.
Yeah, thanks. I have, I guess, 2 questions. You mentioned almost in passing the effect of Tylenol on the CGM sensors. Could you elaborate on that a bit? You're muted.
So we know, I'm sorry. You would really think that I'd get the hang of this by now, right? So we know in patients that take Tylenol, it can interfere with the accuracy of continuous glucose monitors. So if the patient is sick and they're taking Tylenol for flu or illness, I just tell them to make sure that if their sugar is falling below 70, or if it's persistently greater than 180, that they're following up with a backup finger stick, because Tylenol can give an inaccurate read with a CGM.
Does it go in one direction or the other, or is it just off?
It's just off. So both low and high, if it's less than 70 or persistently more than 180, I always recommend a finger stick.
Okay. And then one other question, if there's, if I'm not stepping on anybody's toes, since you're talking to the primary care physicians, and you mentioned you refer people back to their primary care physicians, I mean, you know, yeah, I think probably we all have a good handle on what's going on in our communities and all, but you know, I guess I was just kind of wondering if there's any sort of across the board. It sounds like what you're telling us is if people are pretty well controlled, then they've got a little more possibly flexibility or whatever than other people, a little less risk. But you know, we've got that person. We all know that person who thinks that this is all a hoax and his A1C is 9, and then he gets really sick and he comes back and says, "Why didn't you tell me this?"
It's so true. I can't tell you. Just today alone, in my own personal clinic, I'd say I had at least 3 patients with severely uncontrolled diabetes who are still refusing vaccines. And for some reason, it's like they're willing to get their pneumonia, their shingles, their flu shot. For some reason, it's the COVID vaccine that they're not trusting. And I personally don't know why that is. And I try to educate them. If you do have underlying diabetes, your risk of severe symptoms are much worse.
Yeah.
It just doesn't seem to really make an impact hearing it from me. Whereas previously, if I said that about the flu shot or the shingles, it was really, okay, I'll go get my shingles vaccine at the pharmacy and I'll be back to have it administered. I'll take it to my PCP but for some reason, it's just a different thing with the COVID vaccine. And I don't know why that is. That I think it'd be great to do studies on the psychosocial issues behind why other vaccines are accepted much more willingly and the COVID vaccine's not.
Yeah, and we've talked among ourselves here in the clinic, and maybe Dr. Pollywall I don't know if you're hearing the same sort of thing, but we've got people who refuse the vaccine, no, it's going to kill me, or the government's tracking me, or whatever.
Yes.
But then if they get COVID, they're the first people hammering on the door demanding the monoclonal antibodies. It makes no sense.
I can't understand that myself either, why people are so receptive to the antivirals, to being hospitalized, to getting high dose dexamethasone for treatment of COVID, but not willing to get the prevention, which would be a vaccine. And that's a really good question, Dr. Rexroad, and I don't have an answer. I don't know myself why that is.
Yeah, I think maybe we all just are venting about it because it's so frustrating.
It's really upsetting. And I do my best in my own clinic day to day, but I've noticed there's a lot of pushback. When I tell patients to get flu shots, I don't really ever get that pushback of, well, it's my body and it's my right. And I protect myself and I'm fine. But for some reason, when I recommend the COVID vaccine, there is a lot more pushback. It's like, well, so for instance, my patient this morning said, if my employer, he was employed through Dick's Sporting Goods, forces me to get the vaccine, I suppose I'm going to have to get it. But until I'm forced, I'm not getting it. Again, patient with an A1C greater than 10%. And it's scary, but I don't know. There's just a lot more pushback. Yeah, that's my own personal clinic. And I know that you guys struggle with the same things. I don't have a good solution for that. I really don't know what the answer is to changing the social viewpoints of the COVID shot.
These are all great questions. I really don't know either. Dr. Pollywall, I noticed you raised your hand.
Yeah, thank you for the nice lecture. I have a couple of
Dr.
things. Can you hear me?
Yes, I was saying thank you.
Yeah, one thing is with the new COVID medicine that Paxlovid, okay, it has a lot of interaction, okay, and they have mentioned even for the diabetes medicine. Are you aware of any significant interaction with this 5-day medicine for diabetes?
So I'm glad that Hugh, our pharmacist, is on here, so I can kind of give Hugh my medication interaction questions. I'd say in general, the diabetes, the therapies, as long as these are treating the underlying virus, the hope is that in the long run, it's going to reduce their hyperglycemia. But as far as drug-drug interactions go, I'm going to defer to Hugh to see if you have any other drug-drug interaction.
I don't know if it's fortunate or unfortunately, but I haven't come across the medication yet in any patients, so it's not something I've heard of, but I haven't really looked deeply into any specific interactions. So unfortunately, I can't really speak to that too much. One thing I did want to add, though, to the previous comment with the Tylenol, I think another one to keep in mind these days is vitamin C. At doses over 500 milligrams, particularly with the Libre, the CGM results can be elevated. And there are a couple other interactions that are probably less common. I think it's hydroxyurea with Dexcom and tetracyclines with the implanted Eversense, but those aren't probably as common as the vitamin C and Tylenol ones are, especially with people taking high doses of vitamin C for COVID and things like that. But for the interactions with the new oral COVID medication, I'm sorry, I'm not sure about those.
Okay.
Thanks. I would say that I think the majority of interaction with Tylenol, with vitamin C, is that overall patients will experience falsely elevated continuous glucose monitor readings. So I said high and low, but I tell patients if it's running less than 70 or higher than 180 and they're on Tylenol, and thank you, Hugh, vitamin C, to just do a finger stick to ensure the accuracy.
Another question I have is that regarding that diabetes after COVID, okay, the registry you mentioned, okay, is there any specific feature we are looking for diabetes after COVID, like they developed it within a week after they developed COVID, within a month, or which kind of diabetes we should think of that it could be COVID related? Can you give some highlight on that?
Yeah, so I think the things that I try to keep in mind are sometimes the treatment for COVID includes high doses of steroids. So I'm always trying to be mindful of their medication list and if they're on steroids or if they're on a steroid taper, because steroids can definitely contribute to hyperglycemia. So it can be just medication induced at that point. And you know that because when their taper is off or when they're done with their steroid, their blood sugars go back into a normal range. So that's one thing to be mindful of. And then I tell patients to get a blood glucometer and be checking their blood sugar if they have the symptoms of hyperglycemia. So polyuria, polydipsia, those types of things. And so the cheapest meter that I recommend out of pocket is the Rely On meter and the Rely On strips, and that can be through Walmart. And so checking their own blood sugar, and I ask them to call me if it's persistently running above 180. And so then type 1, to just be mindful of the things that you would see that are different, are nausea, vomiting, inability to keep food down, erratic blood glucose, really high blood glucose is greater than 250. So that kind of gives you more of an idea if it's type 1. Most patients that newly develop type 1 aren't going to just have ketone strips at home. So I would tell them kind of to look out for those symptoms, nausea, vomiting, severe GI distress. Elevated ketones can contribute to that feeling of nausea and vomiting. And so those are kind of the signs and symptoms to watch out for at home. But certainly just, the routine things like polyuria, polydipsia, weight loss, those are the signs to watch out for if they're developing diabetes. And then an A1C, it's one of the easiest ways to screen. So, if they've been hospitalized for COVID and they are having those signs or symptoms, you can follow it up with an A1C in the outpatient clinic to help you objectively kind of see what their sugars are doing.
And is there any duration for that? For example, a normal person get COVID, okay, and then they develop diabetes,
Mhm.
okay, then are
I
you
don't-
seeing a trend like it will be within first 3 months, first 6 months, anything like that?
Yeah, I don't know that. I don't know if it's published yet. In all the case reports and the journal articles I've seen, I don't know if there's an exact duration of time, within 6 months or within a year. That's a great question. I don't know the answer to it.
Thank you.
Thank you all so much for the questions and the great discussion. Did anyone have any other comments or questions? Dr. Rexroth?
I was just going to make one more comment. You were talking about the price of the Rely-On being inexpensive, which it usually is. But if your patient is followed at a community health center, an FQHC or anything, they may also through their 340B plan be able to get something pretty inexpensive. So that may be another option you would be able to refer people to or just to know about.
Thank you. I did not know about that. Thank you so much.
Thank you, Dr. Rexroth. Any other comments, questions? Maybe personal experiences you've had in your clinics and you want to share with the group? Alrighty, well, thank you, Dr. Giordano. Wonderful didactic as always, and so much great information in there. And those statistics, I have to say, I also was not aware of and pretty shocking as well. So thank you for sharing all of that in there. And thank you all so much for the great discussion that really drives these sessions so much. And I really just enjoy listening to you all discuss all these things. So thank you all so much. The only announcement that I have is that our next session will be on February 9th, and Melissa Phillips will be discussing common diabetes medication classes. So keep an eye out for that reminder. I hope you all have a wonderful rest of your day. Take care.
Thank you.
Thank you.
Thank you.
Bye.